Our next session is global events that are impacting kidney patients around the world. My name is Paul Conway. I serve as the chair of AAKP's Policy and Global Affairs efforts. I've been a kidney patient for 46 years. I lived for 3 years on home dialysis. I've been transplanted for 26 years, thanks to my kidney donor, who was a brave young man who obviously didn't anticipate passing away, but he had made the bold decision to donate his organs and to save lives at a very young age as a teenager. And every day that I help AAKP and other patients, I do that in his memory. I'd also like to thank Shiva Roy for remembering our good board member, Brian Hess, and dedicating the last session to him. It's folks like Brian Hess that make a difference and keep things going. For this particular session, we've been very concerned as we look around the world at different events that impact things that are on the news. You can see them, you can read about them, but the subtext to many of those things are the patients whose lives are often not considered or ignored, especially kidney patients. Ed Hickey and I had the rare opportunity to serve under President George W. Bush and helped stand up and create the U.S. Department of Homeland Security after the terror attacks of 9/11 and also the anthrax attacks. In the years that followed, I had the opportunity to serve President Bush as the interim director and also the chief of staff for the Gulf Coast rebuilding efforts of the United States following Hurricane Katrina, the worst natural disaster in United States history. And the lessons that I learned there on the ground have never left me, which is this, that kidney patients and people with complex chronic diseases and multiple conditions are not the first thing that people think about in responding to a disaster. And what that means is that government may have good intentions, but patients and advocates and nonprofit organizations and others need to think far in advance before a disaster ever hits. Today, we'll take a look at several different issues. We'll take a look at what happens during war, COVID-19, natural disasters, and we'll go around the world to do that. Our first guest is a very good friend of AAKP and patients throughout the world, Dr. Ray Vanholder. And Dr. Vanholder serves as the president of the European Kidney Federation, medical association over there that's top line. He's published over 900 articles, and he also served the International Society of Nephrology for a very long time on disaster response. He is an expert in the field. It was Dr. Vanholder that made certain that World Kidney Day this year had that special focus on unplanned events and their impacts on people. And I'd like to ask Dr. Vanholder to go ahead and take a look at some of these issues that are there and some of the work that you've done, Doc, and your reflections on how patients can be better prepared based on the lessons that you've learned. Go right ahead, Doc, and you're joining us from Brussels, I know. Thank you.
Okay, thank you very much. Thank you for the kind introduction. Could I have my first slide, please? Because the topic I will handle together with you is nephrology and crisis situations. And for that, we will go from earthquakes to armed conflicts. The next slide. And that means that you will make the same travel as myself during my career, where I started to serve rescue during earthquakes. Next slide. But then moved on to other disasters like floods or wars. These are the two that I'm going to discuss together with earthquakes to you. But there are also other reasons which I will not discuss, such as torture or also nuclear disasters. Next slide. Now, we will start with earthquakes, and they are certainly the most important natural disaster that exists. Next slide. And the reason why there are kidney problems in earthquakes is essentially due to the fact that muscles get damaged. If people are trapped under the rubble, then they get compression on their muscles, especially when they are lying down when the earthquake occurs. And once they are released from under the rubble, the muscles get damaged and inflamed and release muscle content. And some of this muscle content is the main protein that is contained in muscles, which is myoglobin. That's an oxygen carrier, like hemoglobin. And once this is released into the bloodstream, it travels through the blood and then is secreted by the kidneys. The next slide, where it accumulates in the tubular system of the kidneys. So the black spots that you see on this electron microscopy are tubules that are filled with this kind of gel of myoglobin that blocks the tubular system. That means that urine cannot pass anymore. And as a consequence, people develop acute kidney injury up to a degree that they will need dialysis, or some of them at least will need dialysis. The next slide. And that this need for dialysis could take epidemiologic levels only appeared from the moment that dialysis became available worldwide on a large scale basis. In fact, the first time this occurred was with the Spitak earthquake in Armenia in 1989. And as a consequence, the International Society of Nephrology decided to install a renal disaster relief task force. This renal relief task force was meant to intervene when major disasters like earthquakes were occurring and the local nephrology was not strong enough to handle the whole problem. By the way, I just have to explain that for the time being, dialysis is so much expanded worldwide that this kind of intervention is no more needed, and it is more a need for advisory and logistic support. But the first time that the task force became operational was during the Marmara earthquake, which occurred in summer 1999, where I was the first nephrologist actually to enter the country the day of the earthquake to give support to our Turkish colleagues. And next slide. Up till recently, this was actually the most severe renal disaster that we have ever observed. As you can see from the slide here, there were more than 700 registered patients with acute kidney injury. And I'm pretty sure that not all the patients that were affected were counted. And we ended up with something like 500 patients on dialysis at the maximum in different centers. As you can see, quite a number of these people recovered, and only a small number died. But still, at the nadir of activity, you need enough people around and also enough material around to support those patients, or otherwise they would die. The next slide. I said this was the most severe up till recently. The reason is that the recent Kahramanmaraş earthquake in the south of Turkey and the north of Syria, now already from the few data that we have available, appears to have been even more severe, and they will end up at a number of about 1,000 patients on dialysis under circumstances not of the earthquake, but of the medical surroundings that were obviously better than at the time at the Marmara earthquake, and also the dialysis possibilities, the prevention possibilities, the rescue possibilities were much better. The next slide. Now, unfortunately, we don't have only earthquakes. We have also several other natural disasters. And among these, I'm only going to discuss floods. The next slide. Floods which are becoming more and more severe and also more and more frequent due to global warming. There are more and more hurricanes and tornadoes, and also heavy rainpour, like we observed very recently in the north of Italy, and 2 years ago also in the east of Belgium and the west of Germany. And I remember that also several of those events occurred in the United States. The next slide. And for instance, it was observed in the aftermath of Hurricane Katrina that if those floods are occurring in major city areas, a large number of dialysis units may be affected, which forced, at the occasion of Hurricane Katrina, patients to fled and to go to dialysis centers elsewhere in the United States. At that moment in a relatively unprepared way, so that they missed a number of dialysis sessions, and that was also, next slide, the cause of a large number of complications and the need for hospitalization amongst those patients. That then incurred nowadays patients are better prepared for this kind of hurricanes and know better where to go and what to do. The next slide. Unfortunately, there are not only natural disasters, but also man-made disasters. That means things that are done by men to other men. And of course, this is something that in fact could be avoided if people would be a little bit more kind to each other. But it is what it is. And certainly during the most recent years, we saw an increasing number of wars where also problem of kidney disease was seriously affected. The next slide. So in this second part of this talk, I will devote some attention to wars. The next slide, where there are several factors that impact kidney. From the left on top, there are the military force, which can be wounded, can bleed, can have shot wounds, can also be trapped under the rubble. So there is quite a lot of acute kidney injury. There are bombings of buildings that creates conditions that are quite similar to earthquakes. So again, acute kidney injury. But on top of that, these bombings quite sometimes intentionally are aimed at hospitals. So that means that also hospital capacity is decreased, and that a number of chronic kidney disease patients quite often run into trouble, so that also conditions similar to Hurricane Katrina are created. And for instance, during the first days of the war in Ukraine, when Kiev was bombarded, then hospital activities moved to the basements of hospitals and other buildings. And also, and I will come back to that at the end of this talk, there is an increase of people that are fleeing, and that also creating specific problems for chronic diseases. The next slide. The problem for Ukraine is more or less under control, as you will learn in a minute from Dr. Ivanov. The current problem is the Sudan conflict, where we are confronted with a huge country with a problem of transport, because there is only one exit to the sea and one major harbor. That's Port Sudan. That's the one on the right side in the circle, whereas the major medical activity concentrates on the capital, Khartoum. That's in the square, in the middle of the map. But also all the fighting is concentrating on that city, so that forces patients and also medical personnel to move to other places around the country where transport is not so easy. And on the other hand, dialysis infrastructure is much less expanded. And one of the only ways out is on the north. That's the purple line on top there. That's the border with Egypt. Egypt accepts patients from Sudan, but to get there, I am told that it takes 7 days of travel for a dialysis patient without possibility for decent dialysis. That's of course deleterious. Next slide. And what we fear is a bit that the same will occur as in Tigray in Ethiopia, where an internal conflict was fought between 21 and 22. You see here the figures on dialysis patients in that area of the country with blue bars. So in 19 and 20, when there was peace, the number of dialysis patients is increasing, but once the war erupts, you see a decrease in the blue bars of the number of dialysis patients. And on the other hand, the mortality by the red bars, which is a little bit comparable to what we see in the United States and in Europe in the years 19 and 20, all of a sudden is going up in 21 and 22, just simply because the patients do not receive the dialysis treatment that they deserve. Next slide. So it's sometimes difficult to offer help just simply because it is difficult to reach those countries, and one has transport difficulties, which is certainly what we are observing for the time being in Sudan. And then there is the problem of the refugees. The next slide, where people, for instance, in Ukraine, next slide, have the tendency to move to the east, to the west, sorry, next slide, and gradually are evolving towards Western cities or across the border of the European Union, and were received quite efficiently also in the European Union. Next slide. So there were about 8 million people around in Ukraine, and quite a substantial number also in the European Union. About 1,000 patients on dialysis were treated in the European Union, and we were happy to collect the data on those patients, and those were published just last week in Nephrology, Dialysis and Transplantation, thanks to the work of our Polish colleagues who received most of these patients. And here in blue, you can see what problems we have encountered. So there were about 1/3 of the patients who had an interdialytic interval of more than 4 days, and some of these patients had an interval of 12 days. Of course, that's not favorable and makes them develop complications. Half of the doctors complained about linguistic issues, even if Polish and Ukrainian are somehow resembling each other, and 34% of patients required hospitalization. And perhaps the most important thing, about 3/4 of them were traveling with incomplete information, which makes dialysis, of course, difficult. And that's some of the lessons, that is that every country would need to be prepared for whatever disaster, and that patients always would have all information with them and know where to go. The next slide. And then finally, if we look at what we are seeing as data in Ukraine, as you can see on the left on top, there were 11,000 people on kidney replacement therapy before the war. There are 8,000 now left in Ukraine. And there are about 700 refugees also in part in the Federation, the Russian Federation. But there is a gap of 2,000 patients, so some of them will certainly not have been resisted. But we are afraid that here also some of them will have died, and we will only have clarity once this quite unhappy conflict has finished. The next slide. And the next slide, which then concludes this presentation, and I thank you for your attention.
Thank you very much, Dr. Vanholder. You've been absolutely a spectacular champion for patients internationally and in our efforts, and we appreciate it. And thank you very much also for introducing us to our next speaker. And he is a phenomenal person. For a number of different reasons, we recorded this in advance out of respect for his schedule and also security requirements. Our next speaker is Dr. Dmytro Ivanov, and he serves as the head of the Ukraine Nephrology Association, and he is also the head of the nephrology department at the University of Bogomolets. He has actually published over 500 articles worldwide. His expertise in nephrology and in helping kidney patients and their families was well known before the Russian invasion. But in particular, in this presentation, you will hear about the unique needs of Ukraine and why patients around the world are united with patients that are going through the devastating impacts of the Russian war on Ukraine. Go right ahead.
Hello, dear colleagues. I'm immensely grateful for the invitation and the opportunity to speak at the 5th Annual Global Summit of Kidney Disease Innovations. So let me start my presentation. There are 24 administrative regions in Ukraine and Crimea. By the beginning of 2022, there were 43 million. On January 1, 2023, the population of Ukraine was 28.34 million. During the war, 4 regions were annexed, and about 30% of children left the country, in some regions up to 60%. Up to 50% of medical staff left the country in the first months of the war. These days, up to 80-90 has been returned. This slide presents the history of the development of the military situation in Ukraine. The war began on February 24 and is now continuing over the 15 months. 4-time intervals should be signed out, which significantly change the possibilities of renal replacement therapy. The first stage was the beginning of hostilities, which entailed all the existing changes. There was confusion, and many people began to leave the country with their children. The supply of medicine stopped, and the logistic chains of medical care were broken. The second period is characterized by renewing medical care. The third one was characterized by the total limitation of electricity, and the fourth one almost saved life in non-military zones, which unpredictable situation with active bombing. We could divide the entire Ukrainian territory into 4 zones, from red zone, where active clashes are taking place, to the green zone, where there have been no hostilities, but this zone takes on refugees from the red zone. The greatest load falls on the red zone, where extremely difficult to continue dialysis. It is carried out in bomb shelters and basements, and it's difficult for patients to get to the dialysis center. They stay there overnight and sometimes live there. Some adult people do not receive dialysis, hide in basements, die from underdialysis, exacerbations of chronic process, primarily CKD 4 and 5. The red zone is also characterized by an increase in the number of patients, both military and civilian, with acute kidney injury. This also places an additional burden of dialysis departments. Currently, there are 2 principal zones in Ukraine, where it's calm and where are active hostilities. The first 3 months were very difficult. A shortage of food, medicine, staff, difficulty in moving around the city. In Kiev, all children receiving dialysis were concentrated in one hospital and then were evacuated to the Western Europe, to the Western Ukraine and abroad within months. Adult patients were moved to the central and western regions of Ukraine. Some went abroad as refugees. We stayed to live in the clinic. We have a bomb shelter since the Second World War. The windows were closed with the blinds, you see it's on this slide. In my clinic, both adults and children were helped. The first period of war is presented here using SWOT analysis. The patients were confused. We arranged for them to move to the city dialysis center and my clinic, gave them a kidney book on the self-care, and organized online consultations and medical help. Movement around the city and some areas was practically stopped due to the bombing. So in wartime, patients are ought to be prepared to move to other departments nearby. We have to be prepared to supply patients with individual dialysis machines, have a double supply of dialysis and immunosuppressor therapy consumables to quickly respond to a changed situation, and be ready to attract health workers to replace those who have left their working places. The second phase is characterized by the restoration of the work of dialysis departments and the restoration of the supply of medicines, primarily through humanitarian assistance. This made it possible to restore dialysis procedures and to return to the usual rhythm of work. Most of patients returned to their places of dwelling, and internal and external immigration decreased. The third unfavorable phase is a drastic disruption of the continuous supply of electricity. According to official data, about 45% of energy supply capacities have been destroyed. Electricity is out for intervals of 4-8 hours, which requires generation and ambulatory dialysis. We got some charging station from abroad and humanitarian support, so gave the possibility for continuous ambulatory PD with cycles. There are no interruptions in the supply of water and electricity in hospitals, but we need to organize these difficulties for home dialysis. And with these problems you see on slide, we try to find the real solution. Nowadays, it's reported by Ukrainian Institute of Future the alcohol consumption to be increased up to 30% among the people. This is the situation with transplantation, the last report from our biggest center of transplantation. This is total number of transplants in adults and children in 2023. Interestingly, the number of transplants has increased compared to the pre-war period due to the transfer of transplant activity from the center to Western Ukraine, where humanitarian programs and support from abroad are most active. In the first 3 months of 2023, 90 kidney transplants were performed in adults and children at 19 centers. An interesting trend has developed for children since 2023. Thanks to very active transplantation, the number of children on waiting list began to decrease. In Ukraine in 2022, 12 kidney transplants were performed on children. After additional funding and the adoption of the law of transplantation, the number of transplants is increasing from 2021. Laparoscopic method to a donor, the use of robotics, a simultaneous kidney donor recipient operation began to be applied in Ukraine. Careful selection of a donor, modern immunosuppression, a biopsy with result within a day, this is a digital laboratory in my clinic, allowed us to significantly improve the results compared to previous years, although the results of graft survival are even lower than in the world. In general, comparing 2021 and 2022, the number of transplants in adults increased by 12% and in children by 84%. This is due to the state policy of financial stimulation for transplantation, the implementation of legal regulations that allow transplantation not only from relatives but also from the deceased donors. This is the current situation in Ukraine. As a result of patients' immigration, their death, out of 10,000 patients on renal replacement therapy, today we have about 8,500. Almost 1,700 places have become free. 602 as refugees are received dialysis in Europe, 400 in Russia. So about 700 people have completely fallen out of our care, unfortunately. We had huge international humanitarian support. On this slide, there are 2 children who received the medicine for annual course, which cost about $100 from the American Foundation. Thank you. What is needed in this situation is presented on this slide. The biggest problem is drugs for outpatient therapy and consumables and equipment for nephrobiopsy. On this slide, you can see the activity of our Nephrology Association. We have our own journal together with adult nephrologists and pediatric nephrologists, a website, and 2 regular annual training courses. During the war, we did not change the schedule of our courses. World Kidney Day was held in a hybrid format, which has allowed us to increase the number of use up to 14,000 compared with the usual 500. In September, we are going to organize our next continuing medical education course. We translated the kidney book for patients into Ukrainian. It was a great demand in the first most difficult months. The world community has supported us in our work during the war. Almost every month I have had a presentation in the largest international forums. Thank you kindly, dear colleagues. To put this 1.5 years in a nutshell, we understand our weakness and strengths in the provision of nephrology care. You can see the final SWOT analysis on this slide. This is the results of this war and our experience in wartime. Special thanks for our colleagues from German Society of Nephrologists, European Renal Association, and Task Force Ukraine, and individual support of your dear colleagues. Dear colleagues, once more, thousand thanks you again for giving me the opportunity to share our concerns. Please write down my contact details and I will be happy to answer your questions in person. Thank you.
Thank you very much, Dr. Ivanov, and we will definitely make your contact information available for people of goodwill around the world who want to help fellow patients and medical professionals in Ukraine. We greatly appreciate the circumstances under which you were able to appear with us. So now we're going to go from Dr. Vanholder in Brussels to Dr. Ivanov in Ukraine to our good friend Danny Gallego in Spain. Danny serves as the president of the European Kidney Patient Federation. He's the head of the Spanish Kidney Federation as well. And Danny's going to talk about the practical impacts of COVID-19 and also the assistance that patients in the European Union have given to patients living in Ukraine. So Danny, why don't you go right ahead, and it's a pleasure to have you again.
Many thanks, Paul, for your kind invitation, and many thanks to the AAKP for inviting me today, and to the University of George Washington for being the host of this important global summit worldwide. It's important to remind the kidney patient journey to be aware about the challenges and how we're dealing with the daily life activities, especially if you are young, you will be candidate to 2 or more transplants in your life. And we need to remind that only 25% of people with chronic kidney disease are candidates for transplant because the organ shortage or for another comorbidities. And it's important to highlight the kidney patients are immune compromised, dialysis and transplant for the immune suppressants. And the average years that the duration of the kidney recipients is more or less 12 or 15 years. It depends on the deceased donor or living donor. And we need to remind that the dialysis is not replacing the kidney function, only a small fraction. And the 90% of dialysis patients at center, at dialysis unit in hospitals or in private or public facilities, 3 times per week, 4 hours. So this is more or less the kidney patient journey. There are several events that is affecting the care of kidney patient. One, of course, is very recent, and we are struggling with the COVID-19 pandemic. As you know, during the COVID-19 pandemic, the hemodialysis patients were unable to remain safely at their homes, since and the hospitals and dialysis unit were not the safest places. And we were struggling for the prioritization because the 3 times per week in a public transportation and a public facility, it was a very high risk group with a lot of vulnerability. I will show you the mortality and the infections and of course the hospitalization. And this group is immune compromised and with a lot of problem with mental health, about the fear and uncertainty about the future. And of course, we have seen delays in the vascular access surgery. And in the other group, as you can imagine, the kidney recipients, we have seen pause or delay the diagnosis and the monitorization to check the health status of the kidney recipient during the pandemic, with an immune compromise, with zero antibodies after several vaccines against kidney disease, and with the fear and uncertainty, worsening health and the treatment delays, and without a very clear public health guidance for those groups. So kidney patients were hit the hardest by the COVID due to the high risk mortality, and COVID-19 patients can become kidney patients. You can see here the high mortality during the first wave of the COVID-19. The 21% of dialysis patients infected by COVID-19 have died. So you can imagine the impact in the lives about this uncertainty. And the 20% of the transplant recipients have died too due to COVID-19 during the first wave. The 30% of hospitalized people with COVID-19 patients die of acute kidney injury during the first wave. So the healthcare system were unable to tackle this, And we have seen this healthcare disruption and the access of the continuity of care. We have seen the dialysis sector became a source of infections, and the 80% of reduction of organ donation and transplantation in some member states. So we were claiming for the prioritization because we have been the second most affected group only after the residences of elderly people by COVID-19. And of course, this affecting to the mental health, as you can imagine, the fear to deal with the treatments, to deal with the infections, and for the future. Another important event that is affecting is always the conflicts and wars and on chronic kidney disease and kidney replacement therapy, especially on dialysis. During 2022, we have published in the European Kidney Health Alliance this conflict between Russian and Ukrainian conflict, and we have separated the medical and logistic issues or problems. And you can imagine the refugees for the kidney disease, specific in acute kidney injury, but also in on dialysis, the high risk complications and interruption of the medical treatment, electricity, water, facilities, and dialysis patient complications and dialysis inadequacy, and the transplant recipient complication for interruption in the medication, in the immune suppressant, and the high risk of infections and inability to get access to the treatments or to the medication, and the shortage of nephrologist team or for taking care of the kidney patient. Very recently, last week, we have published this distribution and preparedness and management about the Ukrainian adult refugees on dialysis. We have conducted a survey, and this is the results. You can see here how until almost 30% of the interdialytic interval, more than 4 days, because the displacement, and the result shows that the 50% of physicians reported communication and language challenges for the refugees, and 54% of requires hospitalization. So this survey may help to inform the policies and target intervention for respond special needs and vulnerable population in the future. You can see here we have learned a key learn points about we have shown that 10,000 adults were receiving long-term dialysis in Ukraine during the conflict, and at least 6% of dialysis patients have fleeing out of the country when they start the conflict, to ensure the treatments and the following with the therapies. It was not easy. We've been talking at the major part were to Poland, but the neighborhood, and almost 30% of displaced patients remaining without dialysis for 4 days or longer. So you can imagine the impact on the kidney replacement therapies. Another important events that are occurring during the last years, recent years, is more because the climate changes, the natural disasters, hurricanes, earthquakes, floods. We need to be ready for this because these natural disasters are affecting the damaging facilities, the cause disrupting on the supply chains, and the medications and the treatments are not always to ensure that the supply chain is arriving on time. And you can see here on the right how the kidney failure in disasters are affecting to the acute kidney injury, but also the chronic kidney disease or the end-stage renal disease, knowing or privileged knowing or not knowing, newly diagnosed, and how could end on dialysis. And during the evacuations, it's not easy also to perform dialysis sessions, or to ensure that everyone are receiving the treatment, to the adherence to the treatments is not easy always. And we need to be ready. Maybe we need to create protocols for the preparedness for the natural disasters and chronic kidney disease, because during the climate change and the environmental problems that we have shown during the last years, the wind, fire, snow, floods. So I think it's important to have a protocol for the before the 19 days until the disasters occurs, and we need to think about the air pollution in the future, of how the hemodialysis patients are so vulnerable to the heat waves, because we cannot hydrate ourselves conveniently. So you can imagine how this perfect storm is coming, And I think we need to be ready with this instauring and creating new strategies and new protocols just in case this natural disaster occurring. I'm sure that Raymond, Vanholder, and Dmytro, who are panelists with me in this session, will show how we could be prepared for the natural disasters and chronic kidney disease. And not only are natural disasters or virus or bacteria, human beings and human mankind are creating also political and social events, social determinants of kidney health. And I think economic sanctions, economic problems of the countries could develop some or could create even more problems to the kidney patients. As you know, political instability or disrupt in the supply chains due to the economical or political issues. You can see here more or less the resume about economic or so political legal factors or neighborhood, education, healthcare provision, and also political or economic issues, the difficulties to afford cost of medication or the treatment, the reimbursements, policies, of course, and government policies for dialysis and transplantation is so important to tackle conveniently and law enforcement against the organ trading. I think altogether is so important to show that limiting access to the necessary medication and treatments and all the market options should be available for kidney patients in the future. So we need to make sure that this is sustainable for all the healthcare systems, and we need to think about how the dialysis are producing in the future for without the waste and the a lot of plastic, electricity, water for to maintain the sustainability for the future in the healthcare system. Yeah, I think we need to learn for some lessons during the pandemic or during the natural disasters or the economical geopolitical disasters. I think the lesson for the future is to exchange best practice, that everything that has worked for kidney patients, to best coordination between countries and institutions and healthcare system, or even creating international consortium that could develop between institutions, universities, pharmaceutical industry, kidney patient, nephrologists, also scientific societies, to address and the unmet needs and of course to increase the home therapies. The chronicity should be managed at home whenever it's possible, because home and family is a therapeutic element itself. But of course, we need to raise awareness about the caregivers and to be ready for these disasters or for these events that is affecting the care of the kidney patient. And also telemedicine and phone consultation. Don't leave anybody behind. With new technologies, new devices, and maybe with artificial intelligence, could develop a new ways to tackle chronic kidney disease for the future. This digital transformation in the primary and nephrology connected, primary care and nephrology connected, and as hospitals with digital data in real time. We need more registries. We need more to know the big picture. We need to know how many patients are in every single patient journey and emergency, in conservative management, in kidney replacement therapy, in wherever the patient journey is. And of course, I think we have seen that it's possible to reduce to go to the hospital, because we used to go and reasonable to the hospital, and the pharmacy could be home delivery or pick up delivery without the home or with home assistance nowadays. And I think the kidney patients could add value to every single initiative, because we are special patients with a lot of things that we are managing at the same time. And kidney patient liver experience should be crucial as kidney patient, as a decision maker or a patient consumer, to take the right decision with both choice and co-creation and co-responsibility. And thank you very much to AAKP for the effort and always to collaborate in worldwide with all the institutions. And I think this is the way to make more achievements. And thank you very much for your attention today. And we are here from AKPF to give you all the support and all our knowledge in Europe.
Thank you very much. And I tell you what, Danny is a 20-year kidney patient who has done the journey of dialysis, transplant, and back to dialysis. And he's absolutely somebody who has a tremendously deep level of compassion for other people and for suffering. And that's why he organizes patients throughout the world, and especially across the European Union, to help other patients, especially in Ukraine. So what I'll do now is I'll ask our next two speakers to keep their presentations as tight as possible, because we're already getting a lot of interaction and questions for our panel. Our next speaker is a special guest for us. I've heard him speak before. He's absolutely tremendous, and he's a veteran of many different disasters here in the United States, Puerto Rico, and in the Virgin Islands. That is Yessi Cubillo. And Yessi serves as the emergency coordinator for ESRD Network 3 here in the United States, one of the federal regions that the United States is divided into. And because of that, and because of his location in the region that he oversees, he has seen a tremendous number of different types of disasters, hurricanes, and earthquakes. And Yessi, why don't you go ahead and then we'll move to our next guest in Hong Kong, and then we'll take several questions. So if you could go ahead and hit the top lines of what you've seen in your experiences, Yessi. Thank you.
Hi, good morning, everyone, or good afternoon. I am told that if given the opportunity, I could speak all day, so I would like to thank AAKP for that opportunity today. So I hope you guys are all comfortable. If you've ever been in a conversation with the emergency management world, you've probably heard that let's prepare for worst case scenarios, right? And the idea is that we prepare for worst case scenarios in case we have an event happen. And that worst case scenario would have us being able to refer to plans that we've set in place before that emergency happened. But once in a while, as we've heard today and we've experienced in the last few years, there are events that set a precedent for how we are going to better plan for the future. And those plans that we initially had in place are not up to par with that emergency. And so that's exactly what we experienced with the hurricanes Irma and Maria in the U.S. territories of Puerto Rico and the U.S. Virgin Islands. This is my... There we go. Thank you. Just to give you a visual, I wanted to start with the visuals of what, if you have not looked at a map lately and see where Puerto Rico and the U.S. Virgin Islands is located. This was Hurricane Irma on Sunday, September 3rd of 2017 at 9 p.m. Look at the size of the islands and look at the size of the hurricane heading straight to these small islands in the Caribbean. And so we were closely paying attention to what was going to happen, and ultimately, make sure I got this right, I got it. This is the devastation that the U.S. Virgin Islands experienced. So we have St. Thomas, we have St. John, and you have St. Croix in the U.S. Virgin Islands, and then you have Puerto Rico to the west side of these islands. And you see here, this is St. Thomas, the level of devastation that they had, before and after pictures in St. John as well. And on the far right corner of this slide, you see Schneider Hospital, which is the only hospital, big hospital in St. Thomas, and was heavily damaged. We often think about, if something happened, an emergency happens, where can patients go if the dialysis center is closed? First answer is hospital. This is what the hospital looked like. So the patients couldn't go seek care at that hospital. And as a result, we found ourselves having to make arrangements with the federal government that was on the ground to bring these patients over to Puerto Rico. Fortunately, Puerto Rico did get impacted, but fortunately they didn't have the same level of impact that St. Thomas had, which enabled the capability of them being able to take some of these patients in. Now, I am going to skip a lot of the craziness, let's put it that way, that happened to make it as short as possible, but we evacuated 118 patients, and when I say we, it's in collaboration with the federal government, to Puerto Rico from St. Thomas. And the easiest part of this whole evacuation process, I'm going to tell you, was giving patients dialysis treatment. Surprisingly enough, right? Not everything else that came with it, sheltering, food, medications, transportation, all of that was the hardest part when you have a patient that's moving from one location to another. And reason being is we already had our partners set and ready to accept these patients, bring in these patients. The minute they landed in the airport, they were able to treat these patients directly from the airport to a dialysis center and provide treatment to these patients and receive that medical care that they needed. Everything else after that, the logistics that go beyond that, it's what makes these type of emergencies that much more cumbersome. And so I put these images in there. The transportation of the patients took place 1 or 3 at a time on small planes similar to the one that you see in this picture. So you have an idea of what we were dealing with over a few day period, and making sure that these patients made it safely to Puerto Rico. If that wasn't enough, Hurricane Maria was right behind the Hurricane Irma impact-wise. And so if you've looked at the news recently in the National Hurricane Weather System, there were 2 systems recently that were back-to-back, and I was hoping my PTSD just started kicking in. I'm like, please, don't let this be another Hurricane Irma and Hurricane Maria, that you have them going back-to-back. So what happened is we had these patients sheltered in a convention center in Puerto Rico. It had been set up as a shelter for the patient. After transitioning to multiple hotels that serve as a shelter for them, they were then finally placed here. When Hurricane Maria was coming, the federal government was there as well with the local government. The decision was made to take these patients out of Puerto Rico because, as you can see there, although it looks pretty fortified, that's the shelter operations in there on the first picture. But the bottom pictures is the outside of this building, and it's a beautiful glass enclosed building where you have a Category 5 hurricane heading over to Puerto Rico, straight to Puerto Rico. You do not want to have anyone in there in that building. So the decision was made to take the patients from Puerto Rico and bring them over to Florida so they can continue to receive the care that they needed. And so that did happen. We were able to successfully gather all the patients from dialysis. There were 12 of the patients on dialysis. And from there, leaving their bags, their belongings, and everything behind, just take them, because time was of the essence, taking them straight to the airport so they can be able to get to safety before that a hurricane made landfall in Puerto Rico. I wanted to share with you a little bit of the devastation that also Puerto Rico experienced. The picture to the far right, I took that picture personally because my supervisor and I, Chris Brown, had been deployed to Puerto Rico to help out with the patients from St. Thomas that were there and work with the partners that were working with them. And so we made the decision that instead of evacuating, let's stay there so that we can be able to continue providing support. Once Maria impacts Puerto Rico, they're going to need the support as well, so we decided to stay there. And that far picture to the right, all these pictures actually, I took these pictures from where we were staying at, and the convention center is the second picture from the left to the right, and you can see how scary it looks from that view. Fortunately, the building was not impacted at all. There was a little bit of water that went inside, so it was pretty safe, and it was sustained as a shelter operation for the citizens of Puerto Rico thereafter. In the dialysis center, that was a day after the hurricane. I went into the dialysis centers, and I was able to take pictures and work with the staff. One thing I do want to highlight is that although that picture from the dialysis center looked like that, I did return to that same center 2 hours later. That place was cleaned up and ready to start serving patients and providing treatments. And the reason why is because the staff were there, the patients were there, and collaboratively, together, getting tongue twisted here, together they worked to make sure that this dialysis center was operational and ready to start providing that essential care to the patients. One thing I forgot to mention, St. Croix, also Hurricane Maria also impacted St. Croix and the patients there because of the lessons learned that we had from St. Thomas or Hurricane Irma. We were able to then take those patients directly from St. Croix to Atlanta, Georgia, where they were able to seek refuge. One thing I do want to highlight this, there's some of the major issues that we identified during Hurricane Maria is communication systems failure. We often think that our satellite radios are going to serve us and they're going to be able to provide that communication that we have. If you have a cloud in the sky, we found you're not going to be able to use that satellite radio. So one of the things that were implemented at the Emergency Operations Center in Puerto Rico, the multiple operations centers, they have runners going back and forth from different operation centers getting information. And the same thing was implemented with the dialysis centers, because at that point, now you have multiple dialysis centers across the island, and they're not able to communicate with one another. Patients are not able to find out if my dialysis center is open, can I go to this dialysis center and receive treatment? So there was no method of releasing information to the patients and to emergency managers about what was needed. So everyone was left in silos to defend for themselves and work things through as they deemed necessary. Gas stations, limited supply of fuel. Patients need to get to, transportation, getting to point A to point B. The dialysis centers also need diesel to be able to continue operations with no electricity available. And so that was another barrier that needed to be dealt with, along with a source of water to be able to continue providing that water to the dialysis centers. Rumor mill. This is one of the biggest things that we work with throughout every emergency. I included the map right there of Puerto Rico, and there's a red dot right kind of in the middle. We had word that there were about 30 or something patients stuck in the middle of Puerto Rico, and the roads to get there and to get out of there have been washed out completely. That's all mountains up there. So no one was about to get in their car and go check what's going on with these 30 patients. There was no communication in and out. So the partners that were in the ground at the Emergency Operations Center made the decision, let's send a helicopter in and check on these patients. By the time they got there, it was just a rumor. It didn't really happen. Like, these patients were not there. There was nothing to look further into, because there was maybe a group of patients, but they were able to find a way out. So things like that, how many patients died, are patients dying over here, which creates chaos and it creates confusion in this whole emergency. So we try to mitigate and try to work through all those rumors and try to get the correct information out to our partners, to CMS, to everyone that's interested in knowing what's going on to this patient population. Irma and response, what went well? As I mentioned earlier, and I show you on that picture that I went back to the dialysis center 2 hours later, one of the things that worked well is the willingness and the resiliency of the staff. It's something that we don't often recognize. We talk about patients being prepared. The patients need to have their plans. The patient being able to have what they need. But at the same hand, the staff prepared their patients to a point where the patients knew, if I couldn't come to my dialysis center, whether it be the provider of Fresenius or it be a provider of Atlantis, which are the two main providers in Puerto Rico, I could go to any of the dialysis centers that it's open and is nearest to me, and I will be able to receive the care that I need. And that's exactly what happened during this emergency. They didn't look at, I'm this provider, I'm that provider, this is my patient. No, everything just opened up and said, these patients are able to receive the treatment that they need. We're here to provide that treatment. And the staff, think about the staff who are themselves impacted by whether it be flooding or their homes were damaged. A lot of them lost their homes, yet they showed up to the dialysis center with their families to help clean up and to get that place ready to continue providing treatment for the patients. And that's something that I think needs to be acknowledged, that our frontline staff are the ones that make these treatments and that care continued for our renal population. And they put also themselves on the line to be able to continue that support. Another thing that came up in discussion when evacuating, you see that the evacuation of St. Thomas and St. Croix, you evacuated 100 and something patients from each island. Now you're looking at Puerto Rico, and Puerto Rico is, discussions were open at one point of, do we evacuate the patients from Puerto Rico as well? Puerto Rico has over 6,000 patients. It's not the same evacuating 100 here and 100 there versus 6,000 patients. So one of the lessons learned and one of the things that work well is the collaboration between the partners on the ground to sustain those operations and make sure that there were no patients needed to be evacuated out of Puerto Rico and continue the support that dialysis centers needed. Preparedness activity, one of the things I would like to highlight is that, and a lesson learned and something that helps throughout any emergency. I mentioned at the beginning that if you talk about what can be done to prepare for emergencies, and you prepare for the worst case scenario, you'll be prepared. We have developed a coalition in Puerto Rico that's called the Puerto Rico Emergency Preparedness and Response Renal Coalition, Prepararse in Spanish. And they were established back in 2014. And the initial question that started this whole coalition was, what will happen to our renal community if we have a major event? That was the initial question. It wasn't a what would happen if we have a hurricane, or if we have an earthquake, if we have a drought, if we have island-wide power outage. All of these events happen after the coalition was established. And with each event, you're able to learn from those events, you're able to build on your plans from those events, but most important of all, you're able to build communication and partnerships with the local and federal government partners that are able to provide the support that is needed during these emergencies. And I think the biggest takeaway from this these experiences and these partners, as you can see on the right side of the slide, these are the partners who have developed this coalition, who have been added to the coalition throughout the years. And together, last year we had Hurricane Fiona. One of the things that we have is a WhatsApp group chat. And the reason we learned that is because in Hurricane Maria, there was no communication being in Puerto Rico, but everyone that had the WhatsApp app was able to connect. If you had a Wi-Fi connection somewhere, you were able to send a message and be able to communicate. So with Hurricane Fiona last year, our main method of communication happened through that WhatsApp app. And where there was a power outage, where there was a need, anything that was going on, everything went through that app. And the emergency management responders were aware of what was going on, the needs, and what was needed to be able to continue the operations of the dialysis center. So from Hurricane Maria to Hurricane Fiona last year is day and night. And that's all developed through communications and partnerships, which is what we encourage from now on to do through all of our network regions and be able to have that ready in case of the next emergency, that worst case scenario, as I mentioned at the beginning. Thank you.
Thank you very much, Yessi. And you can see why we're very proud of the fact that Yessi's involved with the ESRD networks here in the United States. He understands how to build the collaborations at the ground level all the way up through the Department of Homeland Security, and that's a key skill set, and he hit it right on the head that communications and relationships matter. What I'd like to do now is move to our next speaker, who's a special guest of ours, and he is known to myself and also to Richard Knight for his work on the Patient Liaison Advisory Group for the International Society of Nephrology, and that's Mr. Bill Wang. He's joining us from Hong Kong. And Bill has substantial patient experience as a kidney patient, and he's also a dual kidney and liver transplant patient since 2018. We came in contact with him directly, watching his presentations during World Kidney Day and also the World Congress on Nephrology this year. Absolutely fascinating perspectives that he has on the other side of the world. So we've traveled right now in this session from Brussels to Ukraine to Spain to Puerto Rico and the eastern states here, and now we're going over to Hong Kong. And Bill, it's so great to have you join us. We're interested in your perspectives on what it means for a patient in the preparation side, and then we have several questions, and I know that you're going to get some of them. So go right ahead, Bill, and thanks again.
Thank you, Paul. I think that the previous speakers lay out a very good framework and for me to sort of summarize the challenges of kidney patients during those unexpected events, and such as war, disasters, and pandemic outbreaks. Imagine the ability to assess the necessary medical care due to disruption in the local communities, as well as the health system, right? Being a kidney patient is difficult enough during the normal times. Now, during the natural disaster or man-made disaster, there are additional challenges that we need to overcome. Imagine the shortage of the facilities and healthcare staff workers available. Imagine that the confusion that people feel are heading with the sudden events. And also imagine that the psychological effects on the patients facing those events. Now, all of these challenges, that they are in addition to the normal suffering of patients in time. So I think the question is, how do we, as patients, can effectively prepare for deal with these challenges? There's one theme in Hong Kong, which the organization, we're also a directors, Hong Kong Kidney Foundation, is we're doing a lot of patient educational work to raise the patients' health literacy and tell them that we patients can be efficient effective patient can be smart just by doing a little bit things that change your habit a little bit, then a very effective patient partner to your healthcare team and to your policymakers even, right? I mean, we always emphasize on the advocacy side of the, you know, the patient advocacy on the policy aspect, on the healthcare aspect. We demand more and we demand this and that, but you know, we can actually do a lot with ourselves just by change a little bit, you know, habit. For example, we as patients, are we stay informed, right? Are we familiar with our own health and safety? Do we have sort of a self-assessment of our status when you know, any unexpected events hits? Do we have ready information? Do we know where to go in the first place? Do we know who to call in the first place? Do we call and other supplies as a emergency kit, right? I mean, those things that, you know, sounds simple, but if you do implement these, it will help tremendously. It's like a fire drill, right? Nobody really takes fire drill really seriously until real fire happens, right? I mean, there are protocols for those fire drills, there are reasons for those procedures, because they are learned um, with life experiences, life or death experiences. So same with the patient experience. I mean, you know, we heard about people talking about war, talking about natural disaster, all the speakers having a tremendous experiences in those unfortunate events. Now, Hong Kong is fortunate enough that we do not have experienced very major events, but you know, COVID hits, right? And also, Hong Kong has experienced a social unrest. Now, you can imagine how difficult the kidney patients will face going to, especially going to in-center dialysis centers to get their dialysis. Now, fortunately, Hong Kong has a long-standing policy called a PD first policy, peritoneal dialysis first policy. Now, that policy was formed at very early stage of dialysis procedures under the hospital of Hong Kong government. Initially, it was out of necessity of resources, a lack of resources. So, you know, hemodialysis is very expensive, and we cannot accommodate so many patients with hemodialysis needs. So we have to resort to other form of dialysis, and peritoneal dialysis is the alternative to hemodialysis, and then it will accommodate of the patient with the dialysis needs. Now, it turns out that that policy has have some resilient during the disaster and natural, you know, unexpected events. So, for example, in the COVID situation, the Hong Kong dialysis patients who are on the home, you know, either home hemodialysis or peritoneal dialysis are doing quite well. They are tend to be less affected by the COVID pandemic, and they have, you know, normal supplies at home, and they have a regular contacts with their physicians and their suppliers. So these things that what patient can do, is quite significant. The other thing I want to mention is the peer groups. Hong Kong has quite a lot patient, patient peer groups, including patient peer groups. They provide the support, both knowledge support, psychological support, as well as the comfort to their fellow patients. And they tend to be the first source of information hub provide to the fellow patients. These works quite well, and especially well during the natural disaster or unexpected events. I understand that AAKP has done a lot of work with their members, and I applaud you for their efforts. Now, Hong Kong is a small place, and so scale-wise, it's no comparison to AAKP. But I think the concept is the same. We have patient help patient, and that's to the medical care professionals' help to the patients, which has been very effective. Now, a couple of people mentioned that international cooperation. This is a very, very important aspect of coping the unexpected events and helping the vulnerables. In Hong Kong's case, because we are just next to mainland China, and mainland China, vast country with the development level varied, so that in some places facilities and medical technologies are not readily available to everyone. So when those areas get hit very hard, China usually gather together the entire country to help those regions and areas in need. Now, Hong Kong play a very special role in helping the vulnerable populations under that situation. Example I can think of is the earthquake of Sichuan province in 2008. Now, Hong Kong sent a medical team, very effective, and set up a dialysis center in a very, very short time. And the uniqueness of that medical team is they get other sort of goodwill visit by politicians and other sort of people show goodwill, show sympathy, and say we need to prioritize our activities to save lives and be effective, and so save your money, give us facility, give us the most needed facilities and equipments, and then we can help the patients there in a tangible way. So there are a lot of things we can do in those difficult situations. Has been doing quite well, but we are also learning from the international experience. I was so fascinated experiences shared by Dr. Ivanov from Ukraine. I mean, it's a real war situation, and they managed to have patients taken care of, well taken care of. I'm also impressed with the the situation in Puerto Rico and that the handling of the event, and I'm also very impressed with the presentation of Dr. Vanholder. I mean, he just laid out from a medical perspective a very comprehensive implications of these events and how, from a medical point of view, what to be. So this, the events like this, let me believe that the international cooperation and international exchange is such an important forum for us to have a chance to share our experiences and learn from each other, and help patients and let patients help patients. And that's my remarks. Thank you.
I'll tell you what, Bill, I sincerely appreciate it. And what we're going to do in respect to time is we're going to gather up the questions and send those out to our speakers so that you can respond. And then we'll also look for other formats that we can go ahead and publish the questions and answers, because I think they're very important for folks. And so in summary, what you've heard around the world today is the fact that, number one, patients are helping patients, and that's vitally important, that clear communications, especially in anticipation of communications being interrupted or broken, are critical, and that those pre-existing relationships exist. And then at the international and national level, the coordination of government response and effective, intelligent response means that patients must be engaged with their medical allies early in the planning process, and to make certain those patient voices are included in everything that we do. Again, I thank each of our speakers. It's been a great tour around the world, many different countries, and thank you very much for being part of our global summit.